All right, well, welcome to the Ultrasound Lecture Series this week. So excited you guys are here, and I am excited to have a special guest with us today. We have Allison Schroeder, who's going to be joining us, who's going to be talking about MSK ultrasound. I just want to read a little bit of her bio. Dr. Allison Schroeder is currently an assistant professor at the University of Pittsburgh Medical Center in the Department of Physical Medicine and Rehabilitation, where she serves as the assistant program director for the PM&R Sports Med Fellowship. She's completed her PM&R residency at UPMC and her fellowship at the Mayo Clinic Square in Minneapolis. She specializes in the use of sports ultrasound for the diagnosis and treatment of injuries. She's authored numerous publications and book chapters related to sports medicine and diagnostic interventional ultrasound. She has taught sports ultrasound at local, regional, and national levels, and she'll be starting as faculty in the Department of Orthopedics at University Hospitals here in Cleveland in July. So I am really excited to invite Allison to this forum. We got the chance to meet a couple months ago at AIUM conference by a mutual friend, Dave Boehner from Ohio State. And just have gotten to enjoy, talking to Allison and learning kind of a little bit about her. And I'm really excited to learn about some shoulder from her. And so I'm going to just turn it over to you and take it away for us.
Awesome. Thanks so much, Matt. Like you mentioned, we'll be talking about shoulder ultrasound. I was told that there have been lectures on kind of basic musculoskeletal ultrasound findings, so I'm not going to cover those things specifically in depth, though they'll be reviewed when relevant to the shoulder. So objectives today, first we'll discuss some basic shoulder anatomy. For some of you, it might have been a while back since med school where we really thought in depth about this. We'll talk through how to acquire ultrasound images of the high yield musculoskeletal structures for those working in the emergency room. And then we'll talk about some findings of common shoulder pathologies that you might encounter. So first of all, the setting that I work in on a daily basis is this controlled environment outpatient clinic where we often do a pretty complete ultrasound. And most of you in the ED are reaching over a lot of people, managing lines, and you're pulling this ultrasound in for a really quick point of care look. And when I'm on the sidelines, I'm doing a little bit more of what you're doing, where you have a question to answer quickly in a short amount of time. So that's what we're going to try to cover today. So my standard protocol of the shoulder, it's pretty well described when we're doing a complete examination. I was looking up what you all do in the emergency department, and I didn't really find any protocols. So Matt, maybe that's something we should think about developing or collaborating on in the future. So I put together what I think are some high yield structures for you all to know, and we'll go through these in the rest of this talk. So like I mentioned, we're going to start with anatomy. I think that you can't become a good ultrasonographer until you understand the underlying anatomy and know what you're expecting to see. So the shoulder joint is composed primarily of the glenohumeral joint with the glenoid part of the scapula and the humeral head part of the upper arm bone, as we all know. We also have the AC joint with the acromion and clavicle there. And then more medially, you have the sternoclavicular joint, which we will also discuss briefly today. Thinking about the muscles and tendons about the shoulder, again, it might have been a while since you really thought about the origins and insertions, but understanding where the tendons come from and go is important. So knowing, the long head of the biceps attaches within the joint on the superior part of the glenoid, and then runs distally through the bicipital groove with the short head attaching on the coracoid is important. The rotator cuff musculature anteriorly, you have the subscap attaching on the lesser tuberosity, and then pec major coming across the top anteriorly. Some of the structures on the coracoid process we're not going to cover as much today, but that anatomy could become important if you have someone with an issue related to any of those. And then laterally, we think about the three posterior rotator cuff muscles, the supraspinatus coming from the supraspinatus fossa and attaching to the greater tuberosity, then the infraspinatus, and teres minor attaching more distally. And I know I've had a lot of residents that have worked in the ER with me, and they're like, how do I evaluate the supraspinatus? That's like the high yield structure. And we'll go through some ways for that can help you identify the supraspinatus and know exactly where you are in the shoulder very easily and quickly. but it's important to remember that the supraspinatus attaches to the superior facet and has some attachment onto the middle facet of the greater tuberosity. And it has a very close relationship to the biceps tendon. So those are all helpful when you're looking for that tendon sonographically. So the rest of this will be case-based because you're going to have someone coming into the ER with some sort of trauma, and we need to think about, what structures do we want to be evaluating. So the first case is a 55-year-old farmer. He's right-handed. He was throwing a hay bale with one arm. He does this all the time, kind of underhand. Felt a pop in the anterior shoulder, had some bruising and swelling immediately. So that is a good history for someone that has a biceps tendon issue. The biceps tendon from a shoulder ultrasound exam is considered the home base of the shoulder. So typically it's imaged with the patient sitting and their palm up, or if they're lying down, you want their arm to be in neutral and their palm up. That helps to bring that biceps tendon, to externally rotate the arm a bit and bring that biceps tendon into better view. And when I'm talking about the biceps tendon here, I'm talking specifically about the long head, which is intra-articular proximally and then runs down the bicipital groove. So in short axis view, so I'll try to orient people a lot with the images. So if you can look at this and tell me exactly what's going on, I apologize, but there might be people here who are less familiar with shoulder ultrasound. So in this image, medial is on the right side, and we have the biceps tendon sitting here in the groove. So this is the lesser tuberosity and greater tuberosity here. Rotating the transducer 90 degrees, you can see that biceps tendon in long axis, and here it's starting to enter into the glenohumeral joint. So these are the two views that you'd want to get of the biceps tendon to evaluate for pathology. So whenever we discuss the biceps tendon or any tendon in general, we need to remember the concept of anisotropy. So anisotropy occurs when the sound beams are not completely perpendicular to the structure of interest. So in this image, it's the same orientation. Here is the bicipital groove with the biceps tendon in it. However, I need to tilt the transducer to bring that biceps tendon into better view. My images are a little choppy. Sorry about that. But you want to make sure that you're not calling a tear just due to anisotropy. So in this case, the patient, had a pop, had some bruising. With the long head of biceps tendon rupture, you can see this Popeye sign clinically, which almost makes the diagnosis for you. And then you'd want to confirm a lack of tendon within that groove after correcting for anisotropy. Other pathology that can be seen with the biceps tendon is a biceps tendon sheath effusion. So in this image now, it's looking at the opposite arm. So lateral is now on the right side of the image. Here is the biceps tendon with an asterisk, and you can see the anechoic fluid surrounding the tendon in this location. This long axis view, again, you can see anechoic fluid above and a little bit below. This fluid is often dependent if you have someone who's sitting, so you want to make sure that you scan distally to evaluate the entire biceps tendon before it becomes muscular, to be able to see if you have some dependent fluid. And you can see fluid around the biceps tendon in the setting of tendinopathy. And if the tendon looks relatively normal, as in this case, you always want to think about intra-articular pathology as the sheath of the biceps tendon communicates with the joint. So here are just some videos. Again, we're up proximally, coming distally, and you can see as we come distally is when we see the fluid. And this one is scanning from medial to lateral along the course of the biceps tendon. The other thing to be aware of in this location, if you do see a fluid collection that's sitting a little bit more superficial to the biceps tendon, especially if you're far proximal, the subacromial bursa extends down into this location. So it's important that you scan proximally and distally to clarify if the fluid is actually around the biceps tendon, or if it's only superficial, it might be within the subacromial subdeltoid bursa. The other pathology that can be seen with the biceps tendon is subluxation or dislocation of the tendon. And this typically occurs when someone has a full thickness tear of the subscapularis and the biceps tendon will dislocate medially. So if you're looking in the bicipital groove, you don't see a tendon there and you're about to call a tear of the biceps tendon, make sure that you also scan medially to the location of the subscapularis and have the patient kind of internally and externally rotate their arm dynamically to see if you can find that the biceps tendon has subluxed medially. So this is an image that's been previously published, and they in the top are showing the normal left side with the subscapularis tendon here and the biceps tendon almost perching, but pretty much maintained within the groove. And then if you look at the other side, you notice the groove is empty and there's the biceps tendon here with no subscap fibers coming down and attaching onto that lesser tuberosity. All right, so the next case, you have a 49-year-old male. He was building a treehouse for his child and he fell. He kind of grabbed up onto a branch. His left arm was forced into abduction, extension, and he had some left anterior shoulder pain following this. He didn't have any numbness or tingling. You didn't have any concern for like brachial plexus or stinger burner pathology. So this is the mechanism where someone could injure their subscapularis tendon. And in the ER, what you're really wanting to rule out and evaluate is if there is a large tear to the subscap. So as I mentioned before, the subscap attaches onto the lesser tuberosity, which is just medial to the bicipital groove. And sometimes when you're evaluating this tendon, it's helpful to find the coracoid process medially. So when I'm scanning for the subscap tendon, I typically start in that kind of home base position over the biceps tendon in short axis and slide a bit medially to then see the long axis of the subscap tendon. And from there, you can rotate 90 degrees to look at the subscap in short axis. So here are some images of that. So I'll scan medially to look at that subscap in long axis and then rotate 90 degrees to see it in short axis here. And it's important to note that the subscap has these characteristic tendon bundles with interdigitations. So if you toggle or tilt the transducer here, you will see that each of these hyperechoic bundles are anisotropic and the hypoechoic areas as well. So this will fill in with tilting the transducer. So you don't want to overcall like a partial tear in the subscap. Then you can also dynamically evaluate the subscapularis tendon by having the patient internally and externally rotate. So with this, you slide a bit more medially until you see the coracoid with its posterior acoustic shadow and have the patient internally and externally rotate the arm. So here we are able to evaluate the myotendinous junction. You can look for any fluid within the subcoracoid bursa, and I have a picture of a video of that later. So this example is, I didn't have any good acute images of a subscap tear, but this is a chronic tear. And when you're looking for a tear, it's the same thing as in any tendon. You are looking for a hypoechoic defect. The cortical irregularity suggests that there has been some chronic wear and tear changes. So here's, this is a long axis view of the subscap, and you can see there's significant cortical irregularity and some hypoechogenicity of the tendon, and the same thing here, significant cortical irregularity. And this is actually a long axis view, and this is short axis, so I apologize, that's mislabeled. And then in that same patient, you notice this anechoic region here, and that is some fluid within the subcoracoid bursa. So whenever I see this, I worry about, is there a full thickness tear of the subscapularis? And that bursa can communicate with the joint in a small number of patients. So you also want to make sure that you're evaluating the intra-articular joint. All right, next case, 32-year-old male. He's maxing out on bench press, felt a pop in his anterior arm, and then had some bruising. So that's a pretty characteristic mechanism of a pec tear. And again, here you're wanting to know, is there a large tear? And this is something in the ER, a lot of times when you're looking at musculoskeletal issues, it's pretty easy to say, follow up with ortho quickly. But this is something that you definitely want them to follow up with orthopedics sooner rather than later, because often, especially if it's an insertional tear, these need to be repaired rather quickly before things start to scar down or the surgery becomes very difficult. So to evaluate the pec major, it's important to understand the complex anatomy. So the pec has a clavicular head and a sternocostal head, and these rotate on each other. So the clavicular head attaches more superficial and the sternal head rotates underneath, and they almost form this U shape with the clavicular head here and then the sternal head coming up underneath. And tears can occur either at the insertion here or more at the myotendinous junction in this location. And I typically will find these again by starting at the home base of the biceps tendon and following the biceps tendon distally. And as the long head of the biceps tendon becomes myotendinous, you'll see the pec tendon in long axis coursing across the top. So here's a video. I'm starting proximally in the bicipital groove and coming distally. And you can see as we come distally that here's some of the pec coalescing across the top. And then if we continue to come distally, that you'll see the biceps coming in its view. This image I took with the patient in an abducted and externally rotated position. If you're doing this with the patient in neutral, you'll see that biceps muscle a little bit more prominently. So this is just comparing a left-sided pec tendon with a little bit of tendinopathy here to the right-sided tendon. And then we can scan both the clavicular head separately. So this all here is the clavicular head, and you can start to see it circle on top of itself before it comes into attach in short axis. And then the same thing, the sternal head, rib, lung below, sternal head of the pec major. And you can see that tendon coalesce, and this now is diving below the clavicular head, which is right here. And then they're all going to come down and attach onto the humerus. And the pec is a relatively advanced structure to scan, but if you're able to scan across the chest and evaluate for a hematoma or a disruption of the tendon and muscle typical fibers, that can be very helpful. So in this image, we have short axis view. Here's the clavicular head and here's the sternal head. And these are courtesy of one of my colleagues. And you can see that typical starry night muscular appearance of the clavicular head, which is lost in the sternal head with some hematoma formation within the muscle. And in long axis, you can see the same thing. The clavicular head muscle is kind of coursing over the top, and the sternal head has begun to rotate deep. But you can see this disruption between the muscle and the tendon. So this is a myotendinous junction tear of only the sternal head of the pec. And if you only scanned, like if clinically the patient seems to have a pec tear and you just scan down from the biceps tendon and you see, hey, look, that looks like that pec tendon's intact, which is what was seen in this case, you need to scan medially to get over the muscle belly, and then you're able to see this disruption. So the next case is a 19-year-old hockey player. She was slammed into the boards, hit on the lateral shoulder. She now has a noticeable deformity in the clavicular region. So again, just recalling the anatomy of the AC joint and clavicle. So the AC joint is stabilized by the acromioclavicular ligament. And then here is the coracoacromial ligament and the conoid and trapezoid ligaments as well that connect the coracoid to the clavicle. And the clavicular anatomy, when we think about areas that are fractured, it's most commonly in the middle third, but second would be lateral third and then medial third. And we will have a bonus case of the SC joint just because that's something that is relatively rare, but you don't want to miss in the emergency department. And the main thing you're wondering here is there a fracture or a dislocation of these joints? So when you're scanning the clavicle, I typically, palpation is always your friend. I palpate the bone laterally, and then we'll scan in long axis medially to look for any areas of step off or fracture. My tip for this is to use really light transducer pressure and a lot of gel. For one, if the patient has an injury there, it's going to hurt if you're giving them significant pressure from the transducer. And two, it's really easy to slide off of this, especially if someone's very bony. If you're pushing hard on top of the bone, it's pretty easy to slide off. So those are kind of my tips for scanning the clavicle. And then you're just going to follow along the long axis of the bone and look for any areas of discontinuity or hematoma. And we'll have a couple of examples of long bone fractures later in this talk. So here are some examples from an article published in Academy of Emergency Medicine, where you have the normal clavicle that I just showed. And anytime you're looking for a fracture in a long bone, you'll see a cortical discontinuity, and oftentimes you'll see hematoma formation. So here is a small, very minimally displaced and angulated fracture. This fracture probably has a little bit of distraction and space between those two areas. And here we have a significantly displaced fracture with some hematoma formation over the top. And then scanning the AC joint, I'll typically do the same thing as when I'm looking at the clavicle, is I just palpate for where the AC joint is. And again, pretty light transducer pressure, especially if they're tender. So this is typical AC joint, acromion laterally, clavicle medially, and you can see the capsule extending over the top. If you ever have a case where you have a really large fluid collection here, which is called a geyser sign, and they don't seem to have AC joint mechanism, worry about a full thickness tear of the supraspinatus. So if you get a full thickness tear of the supraspinatus, that fluid can come from the joint up through into this location and really cause that geyser sign here. So you always want to have that in the back of your mind if you see fluid collection here. And if you're worried about an AC joint separation, you can have them perform crossbody adduction while you hold the transducer over the AC joint. This can be somewhat difficult to do, but here you can see some fluid extending up. This is actually my joint that's been injured in the past. And you can see a little bit of movement of the clavicle in relation to the acromion. So the AC joint, just to recall, and I'm not going to go through it, has 6 different grades of separation that are listed here. In this case that I'm going to show is a grade 3 separation. So in this image, I don't see any acromioclavicular ligament, and you can see that fluid collection billowing up. And this was a case, the same as the previous images that our fellow caught on the sideline of a football game this year, where he not only assessed the acromioclavicular ligament here, but he also assessed the area of the conoid and trapezoid ligaments between the coracoid and the clavicle. So in this image, we have proximal on the right side of the clavicle here, and then the coracoid. And this is the side that was symptomatic. And he had the patient perform this crossbody adduction maneuver, and we don't see like any ligamentous structure really between these two, and they move a significant amount. And on the contralateral left side, which was normal, you can see as they do that maneuver, you see a nice taut band of ligament connecting the coracoid and the clavicle, and below it we have the subscap moving here. So that's a normal ligament versus this side where that ligament was completely disrupted. So the next case is a 58-year-old male. He fell from a ladder, so he didn't have a known mechanism of trauma. He comes into the ER, he's already intubated. You notice a depression in the sternum region near the SC joint. Your CT scanner is backed up, typical busy day. So what are we thinking about here? And the main thing you want to know is the SC joint dislocated in the ER? So here's an image of the sternum and the clavicle. So this side, right side is lateral. You can see typical amount of fluid, I'd say, in this SC joint. And notice the position of my transducer. So it's not a complete transverse view. To get that SC joint, you have to rotate that medial side of the transducer a little bit caudal, to get the good view of both the sternum and the clavicle. And this is just a quick view of a fluid distended SC joint. So now we're looking at the other side. So medial's on the right side of the screen. Here's the sternum clavicle. And you can see the fluid distension. This patient had a significant amount of osteoarthritis with a large osteophyte within the joint, but there was no flow on color Doppler that would make me concerned for an infection or other things. In the ER, this is probably where SC joint evaluation is most high yield, is if someone has a posterior dislocation, because that's something that you want to know and address very quickly. So this image on the right, you can see sternum, clavicle, relatively equal height, and then they scanned their contralateral side, and we have the sternum up here and the clavicle down here consistent with a posterior dislocation. The next case, 74-year-old female who tripped and fell onto an outstretched arm while on her morning walk. She had pain in the lateral upper arm, difficulty lifting her arm out to the side, reaching over her head. This is a pretty common history and something that you probably see in the emergency room often, and I definitely see in my outpatient clinic. So when someone's coming in with lateral pain after a fall, the two big things that I'm thinking about and want to rule out are a supraspinatus tear and a humerus fracture. So like we talked about before, the supraspinatus attaches to the greater tuberosity and it attaches to the superior facet and then the middle facet, with the infraspinatus attaching only to the middle facet and kind of overlapping the supraspinatus here. And then teres minor attaches to the inferior facet. And then when we're thinking about humerus, you can have different part fractures, and the greater tuberosity fracture is the one that most commonly mimics supraspinatus tear, and you probably will see in someone who's a little bit younger than a patient with a tendon tear. So when we're asking the question, is the supraspinatus intact? I think this is probably the hardest structure to scan in the shoulder because it varies so much with the position of the arm. So it's described to scan the supraspinatus with the patient in this full CRAS position. However, most patients have a very hard time getting themselves into that position. Therefore, we use this position called the modified CRAS. So I'll often just ask the patient to put their hand in their back pocket. And if I have them sideline, gravity will help hold their elbow in. But if they are sitting, I'll just stand next to them and kind of keep that elbow in. When you have patients that you're scanning that are on a gurney, if they're able to rotate to be sideline, it will help them get into this position a little bit better for you. And the reason that this position is helpful is because when we're scanning them in neutral, which is this image, you see only part of the supraspinatus here. However, once we put them in the modified CRAS position, it really pulls that supraspinatus out from under the acromion and allows you to fully better evaluate the supraspinatus. So then I typically will look in actually short axis first. So if we have this short axis view of the supraspinatus tendon, I always want to find the biceps tendon again. So it's bringing you back to that home base. So I have them in the modified CRAS, I find the biceps tendon. And once I found the biceps tendon, I know that if I go laterally and begin to wrap around the shoulder, I will be at the supraspinatus tendon. Some people describe this position as like if you're looking at the supraspinatus tendon in short axis, that you have the transducer pointed towards the nipple, versus long axis, you have it pointed towards the ear. That and the angle can vary pretty drastically depending on how far the patient is in modified CRAS or not. So I usually just like to go back, find my biceps tendon, which is here. And then I know if I scan laterally, I'm going to be at the supraspinatus. And those anterior fibers of the supraspinatus are what are most commonly torn chronically, which is, and usually people with acute supraspinatus tears have chronic tears to begin with. So it's a great place to start when you're looking for pathology. So then you can also dynamically evaluate the tendon from the supraspinatus by having the patient abduct their arm. And for this, I'll just bring them back into neutral and just have them kind of chicken wing out. And you can look for any fluid within the subacromial subdeltoid bursa, which is this stripe here. And the one thing that I didn't mention on the earlier slides is the contour of the facets on the greater tuberosity can help you decide what part of the supraspinatus you're looking at. So here, when the facet is flat, you're likely over the middle facet, versus when this facet has a little bit more of a hump to it, you're over the superior portion. So you can see that a little bit better in some other views. And I don't know if I have any great ones that really delineate those two, but that's a piece of information that can help you determine where you're at. And if all else fails, if you get lost, always go back to the biceps tendon. So thinking about moving on to full thickness tears, the things that you're going to see with any tear, especially of the supraspinatus, are focal defects, non-visualization of a tendon, and then secondarily, you can see an effusion or fluid within the subacromial subdeltoid bursa. You can see what's called the cartilage interface sign, which you see here, where you have a bright hyperechoic interface of the anechoic cartilage deep. Same thing here is the cartilage interface sign in short axis to the tendon. You'll see tendon volume loss, where you lose the typical concavity or convexity of the tendon here, and it becomes flat. So this was supposed to be a long axis view of the supraspinatus tendon, and you can see the retracted kind of tendon fibers here, and then just this absence of tendon tissue and absence of tendon tissue in the typical footprint of the attachment. And this layer below here is the cartilage, and there's that cartilage interface sign. Then when we're looking in short axis, you see the same thing where we have this anechoic defect, cartilage interface sign, and you have some tendon tissue on either side. So the tuberosity fractures can mimic rotator cuff tears. So a lesser tuberosity fracture, obviously that's where the subscapularis attaches, can mimic a subscap tear. So if you're ever scanning the subscap and you see, these tendon fibers and long axis look really beautiful, but clinically they seem like they have a subscap tear, you always want to look for this cortical break on either side of the lesser tuberosity here, which is consistent with a fracture. And then the same thing with the greater tuberosity, where we have some tendon fibers coursing across, but you see again this area of cortical break in the tuberosity. And you want to typically see two locations of this area for a fracture. Sometimes if someone has chronic wear and tear changes, you might see like a couple different locations with just cortical irregularity, but these two consistent breaks that are on either side of the tuberosity are very consistent with a fracture. And the other things that can mimic fractures and that mimic rotator cuff tears and that you'd want to rule out in the setting of like a dislocation would be a humeral shaft fracture. And again, this is going to be similar to when we're evaluating the clavicle, where you want to look at the cortex in both short and long axis. I think the long axis view is the most telling, but this is just me scanning from proximal to distal over a normal humerus. And then the same thing here in long axis, we're going from proximal and scanning distally, evaluating the cortex and looking for any areas of cortical irregularity or large hematoma, which we don't see here. And again, a lot of this is repetitive, but I think it's helpful to see different images. So when you're thinking about a fracture, you see this cortical break. There's some distraction of this fracture here, and this is a short axis view where you can see again that cortical break through the humerus. They also describe the periosteal lift. So in a very subtle fracture that you can't see this break right here, you might see just the periosteum elevated without a fracture line, and then a hematoma formation at that site. And that's another clue to fractures in that location. All right, we're almost through the cases. So hopefully everyone's still with me. Oh, and I see the question going back to the cartilage interface sign, so I can go back to that quickly. The cartilage interface sign is not happening from the cartilage being separated from the bone. Typically, the tendon fibers are sitting right on top of the cartilage here, and so you don't see that interface of the anechoic cartilage. However, when you have fluid sitting on top, then you have an anechoic area on top of the anechoic area, and we get this, I think it's considered an artifact of the cartilage in this location. Really nice and high quality machines now, you are able to see that interface of the cartilage deep to some supraspinatus tendons, because the machine is so high quality that it can pick out that difference. But typically we don't see the cartilage, the interface of the cartilage, because the rotator cuff tendon is sitting directly adjacent to it. All right. So we'll go on to that last case. 25-year-old rugby player tackled with his right arm in abduction, felt his shoulder pop out of place. This has happened once before in high school. He had to go to the emergency department to get it reduced, and he's back here again with his arm out of place. And so this is a classic story of shoulder dislocation, an anterior shoulder dislocation. And this is the area where shoulder ultrasound is probably the best well-studied in the emergency department. So there have been one randomized control trial comparing just clinical exam versus clinical exam plus ultrasound for evaluation of dislocations that showed, obviously ultrasound added value. And there's also been a systematic review looking at 10 studies that evaluated the use of ultrasound in assessing dislocations. And it has a very high sensitivity and specificity in the 90s for evaluating ultrasound or evaluating dislocations, and additionally evaluating associated fractures. So this is a great tool for in the dislocation setting, and the type of transducer that you use, the whether it's an anterior or posterior dislocation, the skill of the operator, as long as they've had some training, doesn't seem to affect that sensitivity and specificity. So when I'm scanning the glenohumeral joint, this is the one place where sometimes in the shoulder, I will use the curvilinear transducer. Oftentimes the linear is sufficient. This is a linear transducer with a trapezoid view that gives me a bit wider view. And so to find the posterior glenohumeral joint, it's described in several ways. Some people will talk about finding the humerus and short axis and scanning proximally until you get to the joint. I like to start just caudal to the spine of the scapula and just slide the transducer around laterally. And that brings you right to the glenohumeral joint. So here, lateral is on the right side of this image. You have the glenoid, the labrum here is this triangular structure, and then the humeral head in this location. The infraspinatus tendon courses over the top, and then the posterior deltoid is most superficial. And you can also have the patient internally and externally rotate. So you see that infraspinatus tendon well there as the patient externally rotates, and you can see that humeral head sliding well within the glenoid. This is something you can do to evaluate for Hill-Sachs lesions on the humeral head as well, to see if they're engaging with the glenoid. And so here are examples of the anterior dislocation in the center of the screen. So this is just the normal image that I showed previously. And if you're imaging the joint from posterior, you should see, and they have an anterior dislocation, you should see the glenoid most superficial and the humeral head dislocated anteriorly. So there are studies that describe, drawing a parallel line from the top of the glenoid, and then a parallel line from the top of the glenoid and a parallel line from the top of the humerus. And if that is negative, they have an anterior dislocation. And if that is significantly positive, they have a posterior dislocation where the glenoid sits farther from the humeral head. And then if you're in the ER and you successfully believe that you reduced their dislocation, you can have them again scan the joint. So this was actually a patient post-reduction where we have the glenoid here, labrum, humeral head, and they have a little bit of an effusion within the joint, but that helps you to confirm the relocation. All right, so that was a lot of different cases that I went over quickly. So please put questions in the chat or feel free to ask them if you have any. So I hope that from this you had a little bit of a refresher on musculoskeletal anatomy and understand the importance of knowing this well. I hope that you've got the takeaway that the home base of the biceps tendon is where you start for most structures about the shoulder, and that we talked a little bit about the positioning and ways to optimize your evaluation. And then we covered some of the basic pathology findings and applied them to what you expect from an anatomy standpoint. Here are a few resources if you're interested in learning more about musculoskeletal ultrasound that are from the American Medical Society of Sports Medicine. Initially, they have ultrasound videos for basic scans that go over normal anatomy with transducer positioning. These are free. You do have to sign up and sign in, but you don't have to pay anything to view those. And then AMSSM has also started an ultrasound case series that they have every other Friday, and these are recorded on YouTube as well. So that's another place if you're looking for high yield musculoskeletal ultrasound videos. The AMSSM has some great resources. And ultrasound cases and other YouTube channels also have great opportunities for learning. And a couple of references that are also in the handout. And thanks for having me, and I'll take any questions.